Not all brains are the same. This panel will explore how experts evaluate blood biomarker accuracy in diverse real-world populations, including individuals of different races and ethnicities, and those with comorbidities that may affect readings or symptom severity. We'll discuss how doctors communicate these results and assess whether we're ready to implement these diagnostics across all populations. The question is, are we ready? Dr. Neelam Agarwal of Rush University leads that discussion.
Hello, everyone. I would like to welcome you to today's summit. Today's topic is implementation of an effective and inclusive biomarker strategy. I am Neelam Agarwal, and I'm a professor in the Department of Neurological Sciences at the Rush Alzheimer's Disease Center in Chicago. And I will serve as today's moderator. And I'd like to also introduce our panelists for today's discussion. Dr. Sue Borson is a clinical professor at the USC Keck School of Medicine. Dr. Sid O'Brien is a professor in the Family Medicine and Osteopathic Manipulative Medicine at the Texas College of Osteopathic Medicine at the University of North Texas. And Dr. Chi Uday Momo is a neuroscientist at the Wake Forest University and Aga Khan University in Kenya. So I'd like to welcome all of my panelists today. I am so excited to have you here so that we can have a conversation about this very, very, very important topic. Before we start our conversation, I do want to frame this discussion a little bit and really talk about this important issue of blood biomarkers and tests and how they could be used in clinical settings. Now, we've all heard the media and the news about these recent advances in the use of potential uses of these tests, and simply that these tests have been touted to perhaps make the diagnosis of Alzheimer's disease easier, faster, and potentially have more people come into a treatment modality when it comes to getting disease-modifying therapy. The question that comes up, though, however, is this really what's happening? And is this really what we're going to actually see roll out in the future? Concerns come with infrastructure. Are we ready to handle this kind of testing? Education, not only for physicians that will be asked by their patients about these tests, but their whole healthcare teams. It's not just a physician, it's a team of workers. And importantly, the patients and families and their expectations for these kinds of tests. The other issues that are coming up is how are we going to implement this whole test into the general scheme of how we work now? And how does that have the potential to change how we are going to work in the future? So we have a lot of things to discuss. We have a lot of things to unpack in this discussion, and I know my panelists are just waiting to get started. So I'm going to start off with Sue. We talked about this before, and I really would like to hear your thoughts, Sue, on these tests, these markers. What are your experiences right now as these are emerging, and what are your concerns?
Thank you very much. So the tests are getting better and better and better, meaning they're getting much more accurate in in depicting the likelihood that somebody actually has Alzheimer-type pathology in their brain. So that at the technical level, blood-based biomarkers are just improving kind of apace. They are not currently generally covered by insurance plans. So that's one threshold that hasn't yet been crossed. But the question that I have mostly about them is the idea of diagnosing Alzheimer's disease pathology at a very early stage is most relevant when you're in a system that can provide biological therapies to alter, that we hope will alter the course. And most healthcare systems are not equipped to do that now. So should they be? That's a kind of an ethical question, and it's an economic question about how we spend our precious healthcare dollars. So I think I'm just opening these topics as potential concerns. And I want to make one more comment before we hear from everyone else, and that is that you can't use blood-based biomarkers as population screening tools. This is the wrong idea. Somehow I think people do have the idea that a simple blood test, we can test everybody in my clinical practice or in my healthcare system with a blood-based biomarker, and we're going to know the prevalence of Alzheimer's disease. And that, I think, is a flawed bit of reasoning, and one that should be discouraged. It's not the right way to think about the problem.
And Sue, before I go to Sid, you're bringing this up. So that means these discussions are occurring right now. You're hearing them, right? You're hearing them in the hallways. You're hearing them from even providers, I'm sure.
Yes.
Like, hey, let's just do that. So Sid, why don't you, jump in here and what your thoughts are, and Sue's really good points that she's bringing up.
Yeah, I mean, these bring up, there's a lot of considerations that really need to be hammered out before we can just say, let's run with these things. As Sue pointed out, the blood test, it seems like each year the analytics, so just the technical aspects of the blood test seem to be improving. And that is a huge, huge thing for the field, which I'm ecstatic to see. I don't think the field has been thinking through some of the implications of this. And so, for example, the population screening component, even from a reimbursement standpoint, there are almost no tests in the medical system that are just broadly used for screening. So it's, what are you going to do with this information? And so for me, in that primary care level, it's how exactly are we helping these frontline clinicians, whether it's physician, whether it's a nurse practitioner, PA, whomever, because the patients have real concerns and real problems. And how are we advancing these individuals to the appropriate next steps? Because these frontline tools should be used as a means of saying, okay, you don't need something else. And we can cut down costs, cut down anxiety. And then obviously for me, one of the biggest concerns I have is just a complete lack of representation in the research for these. Our studies are very clearly showing that these markers are impacted by different, race and ethnicity, communities, medical comorbidities. There's a lot of promise there, and I'm very excited. I also am cautious that I want to make sure when we're really rolling these out, we're doing so in a manner that best helps our communities and our patients.
Yeah, well said. So, Chi, what are your thoughts?
Yeah, I mean, these are really excellent points. Absolutely, Sue and Sid. I fully agree. Incidentally, a couple of days ago, a publication on recommendations for the clinical implementation of blood biomarkers, was published online. And so we convened a group, the Global COI, and we really discussed, we thought long and hard about how it can be clinically implemented. And some of the considerations for this, including ethical considerations, that both Sue and Sid have alluded to. So I think our recommendations really, and this represents the viewpoint of this large consortium, was really around the fact that, at this stage particularly, blood biomarkers could be used primarily for ruling out non-AD causes of cognitive impairment. And quite critically as well, we think that its utility at present time as well, despite, of course, Sid mentioned, and it's quite true, the innovations in terms of the diagnostic performance of these blood tests, they're rivaling, the CSF test, the PET test. But then again, with blood tests, they're impacted by comorbidities. They're impacted by racial and other influences. So we think that they could serve as a trial tool right now for further confirmatory testing, like PET scans and lumbar punctures. So I'm encouraged by how promising, these tests are and the advances in terms of their technological capabilities. But I still think, there's such a huge need for further validation in diverse populations. And I'm not just talking of ethnically diverse populations, I'm talking of socioeconomically diverse populations, even if including other communities like transgender diverse. I mean, I could go on and on, but you get what I mean. There's such a huge need to see the diagnostic accuracy across all these groups, because I think it'll really impact how we interpret the results as well.
Yeah, I think, listening to all of you, and my concern has always been, you it's not that hard to order a test. Anyone who does it, it's like 5 minutes. You order the test. It's always for me the now what? The
Right.
now what?
Right.
So, okay, you get it back and it's now sitting in your lap, that test, whoever ordered that test, and it may be indeterminate. Now what? You have all these other pieces that have gone on with this patient and family. How are we going to fold all this in? And how are we going to think about that? I mean, you can say this is one piece of the puzzle, if you will, of what's happening. But a lot of times expectations for patients and families are very different. Like, this is it. This is it. So, let's talk, Sid. How have you approached these issues? Because I'm sure they've come up already. I'm sure that they have landed in your lap. I mean, just give us some ideas of how you've approached this, because it's going to happen as we get into more different populations that are going to be having these tests done.
This is a real issue, and especially when you think at that primary care level, because the vast majority of patients with Alzheimer's or concerns with Alzheimer's, they're seeing primary care docs, and many of them never get referred because of lack of access to specialists. And so that primary care doc, whoever that frontline person is, they get these results, and given base rates, the whole point of a rule out test in primary care is to ease those concerns, because we know 15%, 65 and above would be a high end of Alzheimer's. That rule out component is so important for those doctors, because then they can look at other causes, right? That indeterminate is where, and I've had discussions with primary care docs, I've had discussions with community patients who have had this, and it's almost as if that's like the worst case scenario, because they're still sitting in limbo, right? And so I think we don't have clear systems in place, because some of these tests, actually, you could do even a multi-tiered blood test to get rapid results, because a large scale rule out is not going to have the rule in accuracy. But some of these blood tests could even be a second step. We have to educate families, though. We have to educate the providers, because as a clinician, when you're sitting there with someone and now you're saying, hey, we think you may have Alzheimer's disease, that's not the end of the story. And so these indeterminate components, many of these people and patients and even providers don't have access to PET scans, or their insurance won't cover it. And so we have to think very carefully of how we're going to get through that. And I think there's very clear paths of how we can. But right now, we have people come in our research where they were in that level. And that's one of the reasons they got referred, because they can get these scans for free. And, community members, and all I can tell them oftentimes is, be patient, let's get additional work. But oftentimes the primary care docs are sitting there going, I've had a primary care doc tell me, he goes, I don't want this test again. I don't want it, because I've had so many indeterminates that it's a waste of money and it's hurting my patients. And we got to do better with that one.
Well, I'm going to ask Sue the same question, but I can tell you that time to discuss and counsel, oh my goodness, anyone who's worked in a very busy clinic situation, who has that time? And then more importantly, the question always comes, who's reimbursing for that time? It always does. It does unfortunately come down to a reimbursement issue, right? So a lot of times things get sideswept. But Sue, what do you think about, what Sid is talking about, these indeterminates, and how to handle this when this comes back, and what are we going to do? I mean, what have you seen? And what are your concerns about the trajectory of somebody or a patient's journey of how that's going to end or start, or what do you think?
I'd like even to take a step further back about this, that and focus on the fact that there's been a move toward defining positive biomarker positivity as definitive, a defining condition of Alzheimer's disease. In other words, if you have an Alzheimer molecular biomarker, you have Alzheimer's disease. And I think that's a bit of a tricky issue in the first place. Why? Because a disease usually is something that affects a person. And so we know that there are plenty of people who would be considered at risk for or at higher than average risk of Alzheimer's disease because they have biomarker positivity. But many of them will never go on to have significant cognitive impairment. And given that, I think many of us question this whole equation of biomarker positivity with the presence of disease, as opposed to this is a marker of risk for cognitive decline of the Alzheimer type. And markers of risk are things that are very hard for people to process. It's hard for, we don't have a calculator like the vascular, heart attack calculators that have come from decades of research. We don't have a calculator to tell people this is the likelihood that you and your individual self have this much risk of developing dementia of the Alzheimer type within X years. And I think for me, that's the standard that I want to push the field toward if I have anything to say about it. Because I don't think that primary care docs should be screening their patients willy-nilly. I think I want to get back, Neil, into what you said, which is if we do a test, well, then what? How are we going to use the test? If you're not in a setting where you have access to DMTs, disease modifying and now infusion therapies, only for Alzheimer's, then why do you want to test? Sometimes, let me give a quick example and then I'll turn it back to you. I was talking to a colleague the other day, a neurologist, whose patient in front of her clearly had dementia of the Alzheimer type. The patient had dense lack of insight into her condition. Her family was very concerned, and the issue was now the conflict between the patient and the family around they're telling her, but mom, you have Alzheimer's disease. And she's saying, I'm fine. I'm living alone. I mean, I'm great. So in this case, the patient was unwilling to go through further diagnostic testing, but she was willing to have a blood test. And so the blood test came back positive, Alzheimer biomarkers. She was able to say to the family, yes, I agree with you, but let's not push the issue with mom right now. We can talk later about whether or not she would like to try some therapy. But for now, you're right. I'm validating your observations. But what's most important is the relationship between you and your mom. And you not enter into a conflictual or sustain a conflictual pattern of relationship. Let's talk about what we can do to make sure your mom is safe, happy, and healthy.
Right. So, but Sue, here in that case, what the biomarker was like the definitive, so sometimes we would say the NPath, right? The neuropath is the definitive diagnosis when working in the field. But now this biomarker for this family was the definitive. But suppose
she was clearly affected. She clearly had Alzheimer type dementia. It was obvious. Right.
And so it's being used in that context, right? It's being used now. So just suppose, Sid, you've mentioned a case before where you have a person who can't go through cog testing, and yet it's being used now as, okay, it's going to be difficult to get cognitive testing done for a variety of reasons, language, et cetera, literacy. And so now we're just going to get the biomarker done, right? So if you can speak to that, and then Chi, I want to hear your thoughts on, with our communities that are diverse, what are some of the concerns we're having? And then now what? And they're very big, they're very large, and I'm very concerned about this. So Sid, why don't we talk about the patient the testing issue?
Yeah. I mean, we had someone come in, clearly Alzheimer's, memory loss, verbal fluency, et cetera, not as advanced. However, goes through everything. And we did get a PET scan, amyloid negative. And so this, blood test positive, amyloid negative. And so we're looking at this going, okay, this is something that looks like Alzheimer's disease, but is not. And this is someone who would have been at tremendous risk to put on some sort of DMT because of vascular burden and vascular disease. So, my concerns are, and this is in alignment with what Sue said, is, we need to remember these are people sitting in front of us. These are not biomarkers and these are not profiles. These are real people with real diseases that our responsibility is to help. And we don't have a comprehensive picture because, as Sue said, tons of people have amyloid in the brain, never have dementia. Happens regularly. We also have people, though, who have classic Alzheimer's symptoms who are amyloid negative. And so we need to truly understand these things because there are real risks from these drugs. And so it's how do we put people where on that, like you said, what's that journey to make sure we're reducing the risk as much as we can. And we're also keeping in mind this is a person with a family that we need to maintain family relationships. We need to maintain that love and that bond because we want to maintain that throughout this journey. And so, the patient that we had, she was really mad. She got really mad. Yet her primary care, as we talked before, our primary care doc did the single best Alzheimer's workup I've ever seen, and made clinically the right decision based on what was there. And so, it's just not as simple as people think. Alzheimer's is not one thing. There's a whole bunch of pathologies that can cause memory loss, that can cause depression, diabetes, vascular. And that's one reason why I love the notion of a blood test for rule out, because now those primary care docs can go, okay, wait a minute, not Alzheimer's. Let me look at these other things. There's other things that I can do something with. And so it's not always clear cut. And like I said, these are people. These aren't biomarkers.
Yeah, Chi, what do you think about, these situations?
Oh my goodness. I mean, it's incredible that this is completely unrehearsed just because I'm taking points from Sid and Sue that fits so well with my thinking about this topic. So the majority of my research is done in majority world populations, but of course also underserved and underrepresented communities. And so it's very interesting that even from our findings, when we look back at the drivers of incident dementia, most of them are really down to modifiable lifestyle factors. But even more importantly, I want to give an instance. So individuals of genetically determined African ancestry, often, there's extensive evidence showing that they have lower prevalence of amyloid pathology. So like Sue did, let's take a step back to what these biomarkers we're talking about are measuring. They're detecting brain amyloid pathology levels as usually. And so, of course, if you have someone of African ancestry in front of you, high likelihood of dementia, most likely experiencing higher rates of multimorbidity, including vascular conditions, right? They're testing amyloid negative. What do? Do you send them home? They're more likely to develop, to progress and accelerated progression as well. So for me, it's insane to just only look at biomarkers and allow that to determine clinical outcomes and management outcomes. We need to adopt a more holistic view by, kind of like integrating patient histories and even neuroimaging, but also considering unique health profiles and also thinking about environmental factors that affect different populations. For instance, there are so many, there's data coming out of Latin America now showing that multidimensional poverty, for instance, is one of the biggest drivers of cognitive impairment. So when you, my colleague Michelle Mielke has also published on the impact of discrimination on blood-aided biomarkers and of course comorbidities. So we really need to adopt this more holistic, I think, approach towards integrating all of these different measures when thinking about the diagnostic workup, but also how we interpret the results from the diagnostic workup.
Yeah, no, and I think
underrepresented
you're bringing up a really good point. And I just like to put a plug into patients and families. Please do not underestimate their knowledge of these issues that is affecting their daily lives. They come to us routinely and say, well, Dr. A, what about this? This is in my environment. Dr. A, what are some of these social determinants that I hear about? How is that impacting this test result? Is this test result reliable? And I really want to stress this because, as Sid, you made a point, we are here to do no harm. Sue, you've said that before, ultimately do no harm. And yet, if we don't address these issues of how are these markers impacted by all these conditions, you lose trust with the person in front of you, their family, and frankly, you're going to lose trust with the primary care who are really being asked to do things. And it's like, well, now what? Again, now what? I'm in this mess and you haven't educated us effectively. We haven't talked about this in a process. And that is my biggest concern, that the whole thing together holistically is headed in a wrong direction if it becomes like this is the definitive test, right?
Well, can I speak to the issue of the primary care clinician
Sure.
and the aspect of what is primary care about and why do we care about dementia in primary care? Fundamentally, we care about dementia in primary care, regardless of its etiology, because it causes suffering, right? And the primary goal, the first goal, the always goal of clinical medicine is to heal the sufferer. And so to focus on the suffering as the experience of disease, and then to focus on the disease as an entity that is underlying this and contributing to it, but is not the sum total of the suffering. So when we think about what we can do for people who have cognitive decline, we can do a lot. We can help people with many kinds of interventions that have nothing to do with direct attack on brain pathology. And we forget that. We forget it because our health systems aren't really well designed to provide that kind of multidimensional care for people. The introduction of the guide model as a test, as a trial under the CMS Innovation Center, that's an important innovation, but we can already be doing a lot of this kind of multidimensional care for patients with appropriate linkages. So I think it's easy to get too narrow in thinking about, treating disease is what we do for patients. That's only a piece of what we do. Then the other part about the influences on brain pathology, every day there are important new publications about how one or another factor in a person's lifetime, their lifetime exposure, is manifested now in late life in brain dysfunction. And so if we want to, let's say we filter the air and reduce particulate pollution for somebody who currently has positive Alzheimer biomarkers and say MCI, is that going to change the trajectory of their disease? We don't have answers to that. So we're really up against a burgeoning database that is getting more and more complicated as it gets richer and richer. And I think we should be humble in the face of this and really see that the place of biomarker testing is quite specific.
Well said, Sue.
Yeah, no, very well said. And that leads right into the context of use. Sid, you use this quite a bit, and I really like the term. The context of use is really important because, frankly, that is medicine. We work by algorithms all the time. Sue, you mentioned cardiology and, their risk calculators. And I would like to also highlight patients are used to that kind of thing. They go in and they know if you check this, you get 1 point for this, you get 1 point, you're at a risk for, let's say, heart attack. You are at risk for having a stroke. And the physicians and fields like that look at these calculators modify their treatments based on those calculators. So you're right. We are nowhere near that right now. True. But Sid, the context of use of where in our algorithms, protocols, workups, where should we go with this right now?
This is something obviously, I feel very strongly about. And actually, because of the advances in the field and how good the tests are now, I think previously we may not have even been at a good place to define the context of use. And, I think one of the problems that we run into, because I see this in my community talks all the time, is the way the headlines are talking about these blood tests is, oh, this one blood test does everything. It tells you you're at risk. It tells you you have the disease. If you're going on a drug treatment, it's going. That's not how medicine works. And oftentimes, in most diseases, there's a multi-tiered stage diagnostic screening approach, right? You do a rule out and a second level for that intermediate. Then you do maybe a confirmatory. Normally, a true disease detection takes at least 3 tests, not 1, not 2. And so that context of use is, to me, so important, because then we can explain to that primary care doctor, what does this actually mean? We can explain, if anyone has kids, they got the heel stick with the baby, they do this, and almost everyone has a screen positive on something because they screen for so many things. Well, then as a parent, you're terrified over the weekend, or waiting. But when this happened with me, the doc was able to sit, and I understood context. If you sit, all right, look, you're probably going to get a phone call because so many things, there's so many false positives. Or we can sit with our patients and say, hey, look, if this comes back negative, you do not have PSA. If it's negative, you don't have prostate cancer. And so we can put it in that context. In that way, the docs can tell the patients, it came from a primary care doc, if I had a blood test that said no, an intermediate, if I knew ahead of time that said, oh, I have a second test that's going to help out. So if it comes back intermediate, we're going to do this one. It's going to clarify it. We can outline that journey and reduce the stress. I mean, the number one fear of our patients is dementia. It's it. It's beyond cancer. It's beyond heart disease. That's the fear. And we can alleviate a lot of that and streamline the research dollars, expenditures, and get CMS FDA approval and reimbursement, all by very clearly defining the context of use. Sorry, I get that one. I get excited.
Well, it's really important, because it's a really important point. We have to be speaking in the language of our colleagues, and I think at times we forget this. We're going to put out something. They are working every day using these algorithms or these stepwise, do this, do this, do this. And that is one of the biggest things they ask from me. What are the things you need before, frankly, I hand it off? Before I hand it off to you. And I'm going through my head, this is what we'd like to see happen. I'm worried that the handoff, Sue, is coming right from the beginning. And I'm not even running down the field yet. It's like they're throwing the ball to me, and it's like, wait a minute, you didn't do all these steps, right? You didn't go through the play, if you will. So I want you to comment a little bit about, Sid, the context of use. How do you see this with all the work that you do? How do you see this with patients? Like, who should, in your opinion, not get these tests? And again, I'm doing the rule outs now. Who is the patient in your mind? I'm going to go around the grid here, that you say, this patient shouldn't get it. This patient is coming in worried about, let's say, subjective memory, but everything is fine. My dad has Alzheimer's. Should they or shouldn't they?
Oh gosh. No, I'm thinking, but then interestingly, it's almost like, I mean, we talked. It was so interesting because it was a work group that lasted a year, and so many of these conversations and lots of frustrations, I should say, differing opinions. But I'm gonna present the group's viewpoint, but also my viewpoint here. Yeah, and you ask a really relevant question, right? When you talk about who should get this blood test
and who shouldn't,
who shouldn't get this blood.
No.
Exactly. And you mentioned the role. I think Sid's done an awesome job of defining the context of use, for the blood test in terms of, meeting specific diagnostic performance levels, right? In terms of their specificity and the sensitivity. So you have an awesome blood test then. So what next? I think, so for instance, someone, a Warriwell patient who has come into primary care, they haven't been objectively assessed for objective cognitive impairment. We don't recommend the use of the blood biomarkers in these populations because we think that all that just leads to is unnecessary anxiety and then potentially false reassurance, because most likely if they have family history, they might even test positive, but then they don't have objective cognitive impairment. You know, they can live the rest of their life without developing dementia. Do you put them on a DMT just because they think, you know, they're worried about having dementia? That wouldn't be ethical, first of all. But then we do think for, you know, for patients who are showing signs of cognitive decline, they're coming in with memory issues and difficulties. They, you know, they have difficulties in IADL, for instance. We think that blood biomarkers could be useful both at primary and secondary care settings. And I think, you know, for instance, I mentioned in this context, they could help rule out, you know, the non-AD etiologies before then proceeding with further diagnostic evaluations. So in our paper, we actually define where they could be integrated within the diagnostic workup. But again, I mentioned it's for people with objectively confirmed cognitive impairment or concerning symptoms rather than those that don't have, you know, objectively confirmed symptoms. And we think that they could go hand in hand. So once somebody has come in for done a clinical history, they've had tests, you know, to rule out reversible causes, then we think it could actually be utilized for triaging people towards the confirmatory testing and for further diagnostic evaluations.
Okay. So with that, Sue, I'm going to tip it to you now. What do you think in these cases? Who gets and who doesn't? Who should? Let's say that.
No, well, I certainly agree with your formulation, but I also think, should anybody have a biomarker test if they are not going to have access to a treatment that depends on the presence of a pathology? And I don't think, I think that's a concern. Willy-nilly testing, when mostly what I'm hearing is that even community neurologists who see people with Alzheimer's disease are not able or willing to mount a DMT infusion program. And so they're increasingly funneling their patients to the academic centers where protocols are up and running, and the problem there is capacity. You know, in any given academic center, there's a capacity limitation. So I have real doubts about the value of doing biomarker testing if there is no access to treatment that depends on positivity.
Right. So I mean, and that comes into equity and disparities, and you know, thinking about lessening disparities. We talk about it all the time, and access to care. And you're bringing up a very, very important thing. And
wait, Nilam, can I just add something?
Yeah, Chi, go ahead.
Just because, you know, so I agree with you, Sue. However, I've just come from an awesome experience. It's something called Walking the Talk for Dementia. So I did the El Camino walk with, you know, people living with dementia, their care partners. And during that walk, we were all humans. And it didn't matter that somebody had a biologic definition of Alzheimer's or any other dementia. But these were people living with dementia who had to do the same work. Sometimes they had to hold me because I'm quite lazy. They were helping me. And so I complete that whole hierarchy of patient, clinician, or researcher, participant was completely debunked. And so I do think that there is, you know, the tests help to detect people at risk, and strategies, modifiable factors do show a difference. Because during that walk, we had physical exercise, there was loads of social interaction, and the testimonials that are coming out from the people living with dementia within that 1 week period of having so much fun and, you know, having agency over their own health outcomes within that short period. I mean, it was just incredible. So I think that, yes, we might not have a biologic, you know, therapeutic that works for everyone, but there are other modalities. People could start thinking about maybe taking a walk with family, maybe being more sociable. And we can start to recommend these, and, you know, strategies to sleep better. So
you think
those strategies.
This is the impetus to give them that extra push to make some of those lifestyle changes. Again, exactly. This kind of result. So Sid, what are your thoughts on that? That this could be, you know, that little push. Hey, this is what the test result, I'm going to change. And you've heard it before in clinical. I want to know, it was with genetic testing, right? I want to know my genetic testing because then I'm going to make these lifestyle changes. I want to go to Hawaii. I want to do this. And then I would always say, can you please go to Hawaii now without the genetic tests? I mean, but do you think what she is saying, what are your thoughts on that? It's an impetus to start looking at lifestyle modification.
Yeah, I mean, and again, I always go back to context of use, right? And so there are blood tests that are highly accurate at detecting pathology. Then there are also blood tests that are not, and they're more of blood tests for risk of, or do you have memory loss, right? So my concern for primary care docs is 18-minute average visit with anyone 65 and above. So primary care docs don't even have access to testing for cognitive assessments. And so my work with primary care, one context of use is a screening test, blood test that says risk for just broad-based dementia, memory, not a specific pathology. That then tells the primary care doc, hey, when they come in the next visit, I'm going to spend 10 minutes doing a cognitive assessment, right? So it expedites the process. And the thing about it also is then, all right, screen positive. Now you have all these things you can consider: exercise, sleep, diet, context of use, right? One of the questions that Sue brings up that resonates very strongly is, what's the question, right? And so sometimes the discussion with the doc is, we just want to know, I just want to know what's going on with mom. And if I don't have a therapy, that's fine. But we all want to know. Okay, then it's a negotiation and discussion. These are people. They're not test results. And so I think it depends on the context of use. I do have concerns that Sue brought up about an amyloid screen. You know you're amyloid positive and you don't have access to an amyloid therapy. But the caveat is what we just discussed that she brought up, is if I don't have access to therapy. So the doc needs to be able to articulate that because some of these gaps have gotten worse, not better.
Right. And it does come back. It's a boomerang. It does come back to you. Well, why did you even do this if you know, or if I'm in a certain situation where I can't get this, or there is no access? And it does come up. I'm sure you hear it in the community talks when people say, why would you do that if you know that down here we don't have that, or we don't have the resources, or we don't have the financial transportation to come up for some of these therapies? So one question,
can I add something to this? So what's coming to my mind is dementia friendly America.
Right.
And, I think that what we've heard is maybe having a positive blood test would act as a motivator. It's going to motivate a certain subgroup of people, but the lifestyle changes that we would like to see motivated in patients in general should start much earlier than any biomarker. They should start much earlier, and they should be public health interventions. They should be community-based interventions. So the study I want to see is I really want to test this idea of how motivating is a blood test for sustained behavior change. The truth is that people who are likely to be motivated by a test are likely to be motivated if a doctor says you got a problem. Or we don't know if we can prevent you from developing brain failure. Now, I never use that term with patients, but we're among friends here, right? And dementia means brain failure. That's what we're talking about, a failing brain, right? And so I don't know if I can prevent this for you, but I think in general, these things have been shown to be beneficial for your brain health. And so let's focus on brain health. So I'm not sure that a biomarker test per se has all that much motivating power when the lifestyle changes we're talking about have to be sustained day in and day out, month in and month out for years. And so isn't that we put a lot of energy into thinking about biology when our answers are still quite partial. We don't put enough energy into thinking about how do we change our communities to be more brain friendly. And I think both of our co-panelists here are very interested in that issue. Yeah.
But Sue, I mean, and I'll think about cardiovascular disease, right? How long have we been in the community to talk about know your numbers and get your blood pressure under control? And when you talk to people in the field, they're like, we are still dealing with high blood pressure, stroke. I mean, and I really think this is an honest conversation here. Okay. We are still at it with cardiovascular disease and stroke. and with so much community. And I'm not saying that there have not been strides, but my goodness, I still see in the community these pressures are out of control. Take your meds, know your numbers. And so again, what you're saying, these sustained, these sustained lifestyle changes to kind of track biological is going to be tough. But I do want to bring this question up before we finish up for today. So we've talked about these markers, right? And people are ordering them. And I'm always about the now what. Well, here's the thing. When do you reorder it? Oh boy. This is the thing. It's coming. It's coming. Oh, Dr. Agarwal, I don't trust that. I was in the middle of a treatment and I got that done. And I think that treatment, whatever it may be, is causing those markers not to be accurate. So I want to get this done again in 3 months. And so I'd like to just hear your thoughts on this in the clinical setting now, not research where we're, checking this under controlled situations, but in a clinical setting, how are we going to even approach how often these markers are going to be drawn? And again, the now what, when you get the result and the discussion, et cetera. So Sid, I'm starting off with you with context of use. How often are we thinking about reordering some of these tests?
The thing about these tests that from a dementia clinic standpoint, when I was in a memory clinic, if someone came in concerned, we ran through the whole workup, they were caught, fine. When 12 to 24 months. I don't want to see you unless something significantly changes. I have serious concerns that we're going to go, every 3 months, every 6 months. Look, neurodegenerative diseases move slowly. In the absence of some major event, biologically, social, something that the family feels a huge change has happened, I do not think we should be doing this more than 12 months. I think anything shorter than 12 months could be a problem. Because I think what we're not doing at that point, because to me, one of the best things about a context of use of a rule out is lowering anxiety, reducing patient burden, family burden, medical cost. And so I think that's something that as a medical field, we have to educate the community on that. That is not the community coming back saying, I want it again, I want it again, I want it again. That becomes a very slippery slope, and in my opinion, a dangerous one, because the more times you roll the dice, the more times you get a false positive.
And we know with certain comorbid medical conditions, these markers are not accurate. And,
exactly.
and it's just in that setting, forget about reordering, right?
Absolutely.
Well, with kidney disease and cancer. I mean, we are still learning. So, Sue, I'm going to pop to you about what happens when people saying, don't like that result. I'm going to, genetics, we knew it. You got it, right? But this is a whole different thing. This is like clinical labs, the way things are being presented. So what do you think, Sue, on this? How should we be thinking about it now and approaching this for people who want repetitive markers being drawn?
It's breaking my heart to hear that this is even a question, because I think it's just it's a false choice. It's absolutely a false choice. And I think that people who are demanding repetitive testing need psychiatrists. I mean, seriously, there's it's a fine line between sharing information about new discoveries and feeding the anxiety machine, especially for, I hear mostly from my primary care colleagues, I see too many worried well. Just like I saw too many people with routine Alzheimer's that I didn't need to see as a specialist. They could have been easily diagnosed and managed within primary care. They didn't need my level of expertise. And so I think this is about managing expectations. So this whole I want this repeated test. I want to know whether is my level down now or was it too high? This is a non-issue that we should uncreate. To the extent that we have created this issue, we need to back away from it.
Right. Because again, it's as you said, and this is how it's come up. I'm now doing these things. Chi, I'm going to come to you. The lifestyle changes. Here we go. I'm doing these lifestyle changes, and I want to see how those markers have changed now. Are they better for me? So here again, people are taking it in their own hands. And you're like, oh my goodness. So Chi, what do you think on this?
So first of all, I want to address, one of Sue's comments around the utility of repeat testing. It just takes me back to even the fact that with pets, right, you have the gray zone or peri-threshold. And we have that for blood biomarkers. Absolutely. There's no absolute, like people can transition, people can change different, environmental factors, health factors can influence results. So I'm one of those that actually think there should be repeat comfort, like with the blood biomarkers. I don't think you could just take one test and then that's it. That defines a person. I do think that there may be need to at least repeat it annually to see if there's any changes. For instance, because particularly because of how little we know on the impacts and influences of these biomarkers. So to utilize them effectively clinically, I don't know that you could just, use it currently as like you'd use a brain biomarker test like PET or CSF. So I would be.
But who should pay for that? Who should pay for this repeat testing? This is research. Do I want Medicare dollars to pay for repeat testing because somebody wants a repeat test? I worry about this.
But then should you be using, if we're not certain about the effectiveness or the accuracy then of of the measures, then should we even be offering the blood test in the first place? Because, you could have somebody show, a negative, for instance, or an intermediate range, and unsure whether, the primary cause of their cognitive impairment is driven by, AD etiology. And in such scenarios, then do you leave them to progress without doing anything?
Well, what are you going to do about it? The point is, if you don't have DMTs, you're only going to be doing lifestyle advising, and most clinicians aren't tracking lifestyle uptake. Even if they think that these things are effective, they're not tracking to be sure if it's happening. And so I think that maybe there's a bit of a skew here that comes from, we've all been heavily embedded in academic environments in which we're used to thinking in terms of data. And when you move into the practice space, I think we have to have a different set of measures about how we value what we do. And this is kind of, for me, this is still the driving concept is, I don't want to be pushed around by my patients to order tests that I don't think are valuable to them. And so I think we need to do a lot more, to your point, Neelan, before, about how do we really think about what primary care can and should be doing? How do we know? We need to ask primary care docs what they want to do in this space. We know generally about primary care values, but I think we need to hone in a little bit more on what they feel is valuable to their patients and therefore to practice decisions that they make. And that's kind of what I want that to be a major take home for our listeners.
And exactly. And I think, I'd like to add to that. So we have a primary care perspective that needs to be at this table. And again, how are you working? I cannot stress this enough. To come in and to put things in place and you have no idea what their work environment is, how they operate, how they get through their days, the teams that they have to supervise, I think is going to be very reckless for this. And if anything, it will cause a lot of burnout, even more so than it's occurring. And guess what? Nothing's going to happen. So primary care needs to be at the table. Geriatricians need to be at the table. They also have a different workflow. They also have a very different settings, and we need to hear their thoughts. And then the last piece would be neurology, geriatric psychiatry. These are kind of the four groups that, in my mind, I don't know, Sid, if there are any other groups that come to play as being asked to order. Will you order this? Let's say a patient coming in or a family's asking. But they have to be here on how they work. And how does this make sense to you? And how do you view these things for recurrence of, reordering these tests? My concern is insurance down the road. If you're going to be applying for insurance, are they going to be looking at these test results? Are they going to be mining the data for this? We have it going on right now. We understand that. But I think these are some really key points. Yeah. So I think right now we are up for time. I'd just really like to really thank you all. I mean, it's so terrific talking to you in clinical, in a conversation about how we all think about things, because we need to have these conversations. We need to have these diverse opinions and trying to figure out how to do this. I'm happy, Chi, that you have you're working towards some guidelines, but again, guidelines and adoption are two different things, right? And I think I'd like to just thank, Us Against Alzheimer's really for putting on this terrific summit, and also for everyone attending today. We hope that you have found this conversation interesting, that you've learned things just as we all have. And thanks again for your attention.
Thank you, Dr. Agarwal, and to our entire panel. Up next at 3 o'clock Eastern, a special fireside chat with U.S. Senator Mark Warner. We'll see you then.